Today I'm going to talk about a very common but very important topic. That's management of abdominal pain. Being an emergency physician, when a patient comes to you with any symptom, first and the foremost thing you need to realize and you need to identify is the patient stable or not. Likewise in abdominal pain. Abdominal pain carries range of differential diagnosis. But is this important for you as an emergency physician? Yes, it is. But after making the patient hemodynamically stable. If the patient is hemodynamically compromised, these diagnoses won't help you, or looking for diagnosis might end up losing the patient. So first, no matter if you know the diagnosis or you don't, knowing the diagnosis is good, but it's not worse. So if a patient is in life-threatening condition, treat the condition first, then look for the cause, what made that patient into life-threatening condition. So we start off with how to approach a patient in emergency department with abdominal pain, keeping in mind this approach remains same for every patient in emergency with any symptom. What to do first as an emergency physician? Common complaints of abdominal pain. First and the foremost thing, A, B, and C. Airway, breathing, and circulation. How to maintain an airway? Look if the patient is breathing or not. Look the oxygen supply is enough for him or not. Look for the clean airway. If the oxygen concentration is low, provide him with oxygen, irrespective of what he or she is presenting with. If you find decrease in oxygen levels, first thing, as an ED physician, O2 supply. Next, breathing. Is the breathing symmetrical? Is the pattern symmetrical? There is any disequilibrium in the breathing pattern. All this you need to realize, because that's what makes the person condition worse and can cure the patient in minutes if treated and dealt appropriately. Third thing, circulation. Again, an important thing. Are the organs being perfused? And it's related to oxygen supply as well. Are the organs getting enough oxygen or not? So again, irrespective of what the symptoms the patient is presenting with, A, B, C. Remember these three words for emergency department: airway, breathing, and circulation. Now coming again, if a patient comes to you with abdominal pain, first again, check for ABC. Next, look his or her mental status. How would you do that? General appearance. Mental status. Do you see an ill patient? Is he or she ill looking or toxic looking? That gives you an idea that how badly this patient needs treatment intervention. Brief abdominal palpation. Before even brief abdominal palpation, vitals. Vital signs, blood pressure. If it's low, it's hypertension. Treat hypertension first. Look for pulse. If the patient is tachycardic, the patient is going into shock, or there is decrease in pressure, if there is any compensatory mechanism going on inside, you need to treat before that compensation goes into decompensation. Look for respiratory rate. Again, very important thing. Look for oxygen saturation. Temperature is an important part of vital signs. As mentioned in the slide, record vital signs after securing airway, breathing, and circulation. Assess the general appearance. Is the patient ill looking, toxic looking, or you feel like this patient needs something? He's not doing well. Think of a major complication going on inside. Brief abdominal palpation. If you just inspect an abdomen and you see a pulsating mass, think of aneurysm. If you see guarding, if you palpate and you find guarding, that's an important marker. That can be pancreatitis, that can be perforation. Rectal examination for blood in the stool. If possible, do rectal examination. That can give you or provide you information, is there any GI bleeding that's coming out from rectum or not? What next to do? Hypotension, shock, pulsatile abdominal mass, board-like abdomen. Board-like abdomen, you can get in acute pancreatitis, peritonitis, and that needs emergency treatment. So how to treat hypertension? Shock. Fluid replacement. So if there is no hypertension, shock, or symptoms that are present on this slide, no need to worry. Proceed for general examination, how you proceed to a patient. Take a history. Physical examination. Precisely emphasize on abdomen. Pelvic and rectal examination. Lab tests, lab investigations, blood test, renal function test, electrolytes imbalance, lipase urinalysis, pregnancy test. I'll explain more further in the coming slides. ECG, it's very important. Abdominal and chest X-ray. So, if you're sure the patient is stable, his GCS is 15/15, he is alert, he's maintaining his airway, oxygen saturation is adequate, blood pressure is adequate, mean arterial pressure is adequate, relax. Go ahead to the patient for further examination and evaluation. So, then consider possibilities according to location, right upper quadrant pain, epigastric pain, left upper quadrant pain, flank pains, precisely including renal system, lower abdominal pain, crampy, variably located pain, and diffuse steady pain. These types of pain, I'll explain more further later on. What if the patient is not hemodynamically stable? This might need surgery, emergency surgery. So first thing to do, notify the surgeon. Call the consultant on call. Tell him or her, this patient is in danger. We need to intervene as soon as possible, irrespective of what was the cause of it and what's the diagnosis. First, we need to save life. That's life-threatening. Save it first. 2 large bore cannulas. Hypertension, treated with fluids. 2 large bore cannulas, at least 3 liters of crystalline fluids, IV fluids, essential. Maintain blood pressure. Maintain mean arterial pressure more than 65 millimeters of mercury. It's important. Bedside ultrasound. Many hospitals do have bedside ultrasound. It gives you a very good information about is there any peritoneal fluid inside? Or is there any food fluid collection inside? How about the bowel movements? Is there any rupture intestine inside? It gives you very good information. Blood for test, blood for ABO cross-match, blood for grouping. Very important if a patient needs surgery, he needs blood. Send blood to lab for cross-matching. Start infusion, as I said before. Urinary catheter. Very important. You need to measure the urinary outcome. It shows the renal system is being adequately perfused if the outcome is adequate. For example, the outcome is set in shock as 0.5 ml per kg per hour. That should be the minimum outcome if a person is hypertensive and getting fluids. Arterial blood gases, very important test. It demonstrates that blood gases, acid-base levels inside. Very important. If not with resuscitation with fluids, and there you have given 3 liters of crystalloid solution, but there is no response, and the patient is not getting well, there's persistent hypertension, and there's persistent shock, then you need, the consultant surgeon needs to intervene and proceed for explorative laparotomy as soon as possible. So, yes, obtain chest x-ray and perform laparotomy as soon as possible. Begin antimicrobial therapy, very important. In shock, it is said that antimicrobial, if you are suspecting an infective cause or septic shock, antimicrobial should be given within first 2 hours. It saves life and it's very essential component. As I mentioned before, if a patient is still hypotensive, you need a consultant surgeon to call to and to intervene as soon as possible. Who needs surgery? That's a major concern. If you find a pulsatile mass, thinking of aneurysm, needs urgent surgery. If a patient is in shock despite adequate treatment, he needs surgery. Or there is GI bleed, persistent melena, persistent hemoptysis, he or she might need surgery. Before going further, as I mentioned in the beginning of this slide, in emergency, you can just go for brief examination, just to have some idea what might cause the condition of this patient. So moving ahead, hypotension, again, it's a very, very concerning point. I'm mentioning it again and again because that's where emergency has to intervene. Even before the surgeon, emergency physician needs to treat hypertension as soon as possible. Hypertension can be due to abdominal aorta aneurysm, ectopic pregnancy. Peritoneal signs, board-like rigidity. Patient won't let you touch his or her abdomen. He will feel pain. That's an acute surgical emergency. He or she might have intestinal perforation, or peritonitis, or severe appendicitis, or pancreatitis. Pulsatile mass, abdominal aortic aneurysm. If we suspect this, you need surgery. This can rupture anytime. Benign abdominal mass, mesenteric ischemia, acute MI. What happens in mesenteric ischemia? What are the possible predisposing factors that might cause mesenteric ischemia? That might help you as you're treating this patient that he might be having mesenteric ischemia. So you can provide him or her with anticoagulation. Pre-existing atrial fibrillation, deep venous thrombosis, elderly male, bedridden, not mobile, can cause mesenteric ischemia. Any left ventricular clot that can move can cause mesenteric ischemia. So red flags again, mesenteric ischemia, these are sudden onset, excruciating pain. If a patient comes to you that he was doing fine and he gets excruciating pain and they don't know what really happened, think of mesenteric ischemia, think of a bigger thing. Think of abdominal aorta aneurysm. Think of abdominal aorta rupture. Think of peritonitis. Perforation, gastric perforation. The patient who has a history of ulcers, duodenal ulcer perforations. What you get? Tender, board-like rigidity. That's an emergency. You need to proceed for emergency surgery as soon as possible and close that perforation. Aortic dissection. There are two types, which one involve descending, and one goes ascending. Ascending aorta dissection needs surgical treatment. Abdominal aortic aneurysm, ectopic pregnancy. Ectopic pregnancy is also an emergency. So red flags continued. Ripping pain, history of vascular disease before. What is the most common cause of mesenteric ischemia? Atherosclerosis, as it goes around for coronary angio arteries. Most common cause, atherosclerosis. So ripping pain, abdominal aortic aneurysm, aortic dissection. The pain might radiate to back. Very important. Red sign. History of risk factors for coronary artery disease. MI, mesenteric ischemia. Again, these are emphasized again and again because they are really, really important. Because if they are not treated in timely, you can lose the patient. History of abdominal surgeries, bowel obstruction. Most common cause of constipation in elderly patients, adhesions. And post-operative patients, adhesions. The surgery might cause adhesions. It leads to constipation. So now comes your prolonged management. When the patient is hemodynamically stable, now you can proceed for your history and further examination. It is said the pain is the most important presenting complaint in emergency department. So when a patient comes to you with pain, first and the foremost thing you have to do after this hemodynamic stability, relieve the pain. It is commonly said that if a patient is not in pain, that might mislead to diagnosis. No. That's what he or she is coming for, to get rid of that pain. If you, as an emergency physician, keep that patient in pain just for the fact that you might know the diagnosis, that's wrong with the patient. That's not what he or she is coming from. He or she is coming with the pain. Treat the pain first. Diagnosis can be identified later on. So, history. Ask questions about the pain. Where is the pain? Has it migrated anywhere? Sometimes patients present with paraumbilical pain or epigastric pain. The patient might complain it started off with umbilical pain, but now it's migrated to right iliac fossa. That's something to think about. Or the patient presents with, I have an upper epigastric pain, abdominal pain that's radiating to back. Or I have a flank pain that's going down to my groins. That's an important question. That can make you or make things easier for you to diagnose this patient. Does the pain radiate anywhere? Is it going to the right shoulder, as in cholangitis? Is it going to back, pancreatitis? Is it going down to groin, renal colic, ureteric colic? Is it in right iliac fossa, ectopic pregnancy? Multiple things you can get with just simple questions. What were you doing when the pain began? Were you eating something? Did you jump on something? Any history of trauma? Anything? Help. What does the pain feel like? Excruciating pain? Thrombotic pain? Dull, intermittent kind of pain? Associated with cramps or not? Excruciating pain and swear pains are really, really important, because that shows the problem is bigger inside. So that can be aortic aneurysm, mesenteric ischemia, acute pancreatitis, appendicitis, multiple things, perforation, cholangitis, multiple things. You can think if the pain is excruciating. I'll explain more about the pains by the end of the slide. How severe is the pain? In the section of pain management, This is how a patient tells, or this is the tool, how the patient can communicate to you how much he or she is in pain. There are multiple tools to identify it. The most commonly used numerical scale. That's 0 to 10. 0 being the least or no pain, and 10 being the worst pain of the life. So you ask this patient to rate his or her pain on the scale. And that's the best way to assess it. That's really important. Was this pain a sudden or gradual onset? Is it going for days? Or you were having nothing and you started off with the pain suddenly, acutely. There were no preceding factors. There were no preceding signs and symptoms. As compared to chronic pains or gradual onset pain, there was a label pain in the past 3 days, but now it's getting worse. And that's how a patient presents. With sudden onset, patient might say, I was doing my normal job. I was doing my normal work, daily routine work. I felt a thrombotic kind of pain, excruciating pain in my abdomen. I don't know. That's the worst pain I ever had. That needs attention. Something must click in your mind that this patient has something bigger inside. Anything that makes pain better or worse? Does walking make it worse? Lying on a certain position make it worse? Any pain medications makes it feel comfortable or not? Important point. So, visual abdominal pain. As I mentioned before, the onset of the pain is really, really important. For example, a patient comes to you with acute pain, acute abdomen, and the abdomen is rigid, hard, board-like, doesn't allow you to touch. There are multiple things that must come in your mind. Is this acute pancreatitis? If it's a female, if she has a history of pregnancy, ectopic pregnancy? Ruptured aneurysm, biliary colic, renal colic. Renal stones can present with this pain. The patient comes to you and said, I have a massive amount of pain and it is at its peak. It's not going off with any medications or any maneuvers. Treat the pain first, then go for diagnosis. If a patient comes to you, again, sudden onset of pain, but the pain is getting worse, you can add multiple more diseases in it. For example, mesenteric ischemia now. The pain can get worse. It started off with a high magnitude of pain, but now it's getting worse. So that's sudden onset, started off with moderate pain, and gradually and abruptly increasing. It's not stopping. Next, gradual onset of pain. There was a label pain a few days back. A patient might come to you, there was a little bit of pain a few days back, but now it's getting worse or getting more and more with passage of time. Think of cholelithiasis, cholecystitis, appendicitis, diverticulitis, important differentials that you might know with just few words, few questions. Even you didn't touch the patient, but I'm not telling you this is your key points to remember for diagnosis, no, but this can narrow down your differential diagnosis and help you in making an approximate or appropriate diagnosis. Intermittent dull pain can occur with constipation, inflammatory bowel disease, and gastroenteritis as well. Sometimes there is no pain. Patient might complain to you, I don't have a pain, but there is heaviness inside my abdomen. That can be abdominal fullness. For example, patients who are bedridden, who have a history of constipation, who cannot pass the flatus, gas content gets inside, accumulates inside. So they give them a feeling of abdominal heaviness, fullness. So visceral pain are poorly localized because that's coming from a viscera. Distension and stretching of all organs can present pain. Again, they can be gradual in onset to excruciating pain or starts off with an excruciating pain. Needs to be differentiated. Epigastric, that's up in the abdomen, paraumbilical, around the umbilicus, infraumbilical, or lower abdominal pain. Depends on location. Lower abdominal pain, hindgut structures might be involved. Parietal pain and referred pain. Parietal pain is well localized. It is innervated by somatic nervous system. These are well localized. The patient will feel the pain even if you touch it. So, what is being innervated in abdomen by parietal somatic system? It's parietal peritoneum. So even if you touch a patient with peritonitis, he will shout on you. This pain will excruciate. He won't let you touch. Next comes referred pain. Sometimes, even in MI, many patients can present with epigastric pain, especially in patients who are diabetics. They have atypical presentations of MI. So, first and the foremost thing, if a patient with risk factors, for example, diabetes, hypertension, obesity, and comes with epigastric pain, I really suggest go for an ECG first, after pain reduction. Referred pain can be to the shoulders as well, with diaphragmatic irritations. Right shoulders, commonly with acute cholangitis. Or the pain is referring back to the back, to the groins. These are very important. Before moving on, apart from abdominal pain, though the topic is how to manage abdominal pain, but this can present with multiple other symptoms. For example, fever, a rash, urinary symptoms, gastritis, loose stools, diarrhea, vomiting, nausea, anorexia, weight loss, dehydrations, multiple things. So it's not just to be concerned about the pain. Many other symptoms are associated with it. So, moving on, concerning diagnosis and abdominal pain. Abdominal distension with bilious vomiting. Think of pyloric stenosis. Bilious vomiting. What happens there is a pyloric outlet from the stomach. The food propels out of it to the duodenum. With the obstruction or hypertrophic smooth muscles around this pyloric stenosis, there is backtrack of the food cannot be propelled into the duodenum. So, patients vomit it out. So that's a bilious vomiting. Bowel obstruction, as I said, malrotation, volvulus, these are important, and abdominal distension. Fever, right upper cardiac pain, and jaundice, more specific with cholangitis. Ascites, multiple reasons for ascites. Hepatic failure, most common. Hep C-related decompensated liver diseases. Again, a common variant for ascites. Portal hypertension, a symptom or a sign of these diseases I mentioned before, DCLD, decompensated liver diseases. Makes portal hypertension, ascites. With ascites, increased chances of bacterial peritonitis. So, spontaneous bacterial peritonitis. Blood in stool. Blood in stool, it's an emergency. Rectal examination at the primary cervi and you find blood, look for there is a GI bleed inside. Needs emergency intervention. It's not an easy thing. Colitis, interception, and IBD, inflammatory bowel disease, can be other causes of blood in stool as well. You see, abdomen can contain large amount of volume. We have multiple pouches, Morrison's pouch. What happens is, with the bleeding inside the gastrointestinal system, there's increased risk. There's a lot amount of blood is lost inside the abdomen because the capacity that it can have for fluids. So, if a bleed comes out, think there is a massive bleed inside. So, differential diagnosis by location. These can ease things out for you when examining a patient or palpating a patient. It's with the areas involved and the organs underneath those areas. So starting off with the right upper quadrant, acute cholecystitis and biliary colic. Sometimes you do get Murphy's sign. Murphy's sign is very important. What happens is the patient inspires, and when you palpate the right hypochondrium, with Murphy's sign positive, the patients hold their breath because of the pain. That's Murphy's positive. It's important. Acute hepatitis, hepatomegaly, right upper quadrant involvement, acute pancreatitis and appendicitis. Though appendicitis may commonly present with paraumbilical or radiates to right iliac fossa pain, but sometimes it can be elicited with palpation of right hypochondrium. Likewise, in mid-epigastrium with pancreatitis, the pain usually in mid of the abdomen, but sometimes with the right hypochondrium palpation, this can be elicited by pain. Perforated duodenal ulcer, a very, very important disease. Important disease in respect that it needs treatment early as possible. Lower lobar pneumonia, sometimes with the diaphragmatic irritations in the right side of the chest, can cause pain in right hypochondrium. So you need a chest x-ray if you're suspecting if there is a pain in right hypochondrium. Myocardial ischemia, herpes zoster. Herpes zoster is a viral disease. You can have skin infection. That can lead to right hypochondrium pain as well. Now, left upper quadrant pain, gastric ulcers. Again, acute pancreatitis. Gastritis can lead to left upper quadrant pain. Myocardial ischemia and aneurysm. You see, abdominal aorta bile arch is in the mid of the abdomen. It's just a rough estimate. So if you're suspecting an abdominal aneurysm, or if there is abdominal aneurysm, so the pain can be central or in the left upper quadrant. Left lower lobar pneumonia, again, the same mechanism. Diaphragmatic irritation can cause left hypochondrium pain. Right lower quadrant pain. Appendicitis, hematoma. Look, appendicitis is a very, very important diagnosis. It can be diagnosed clinically. Sometimes, or most of the times, it doesn't need any scans or radiological studies to confirm if it's appendicitis or not. There are multiple scores or guidelines that tells you if you are suspecting appendicitis, that's how you get a patient with appendicitis. So a patient, especially in young individuals, a person comes to you and I said, I have a right iliac fossa pain. First thing, think of appendicitis. Young patient with nausea, vomiting, and a little fever, slight fever, mild temperature going on from past 2 to 3 days, and there is a history of radiation of pain, think of appendicitis. Next thing, palpation comes next, and later on rebound tenderness, or blood tests would show neutrophils or right-sided shift of WBC count. That's something else. But right iliac fossa pain, first thing, appendicitis. Hematoma, cecal and Meckel's diverticulitis. These are also important diagnosis and right lower quadrant pain. Endometriosis and inguinal hernia. Right iliac fossa, there is inguinal canal and right iliac fossa. So highly suspicion of inguinal hernia. How do you ask a patient? Cough reflex, ask him to cough. If there is any bulge in right iliac fossa, think of inguinal hernia. Rupture abdominal aortic aneurysm. Again, can present with right iliac fossa pain. That's an emergency, needs treatment. Crohn's disease, ulcerative colitis. Ureteric calculi. As I told you, flank pain radiating to groins, think of ureteric calculi. What happens is the ureteric calculi, or in simple words, ureteric stone, that when it moves causes pain. So the dermatomes, the sensory supply to the areas that are supplied with by the flanks is also innervated with the groin. So if there is a pain in flank, it radiates to groin. So sometimes in right iliac fossa. So left iliac fossa or left lower quadrant pain. Inguinal hernia again. Endometriosis, enteritis, gastroenteritis can lead to left iliac fossa pain. Rupture aortic aneurysm. Important thing. Rupture of psoas abscess. Rupture ectopic pregnancy. See, if a female comes to you with left iliac fossa pain, the first thing, as an emergency physician, if she's married, rule out ectopic pregnancy. Because when ectopic pregnancy gets ruptured or it's causes complication, you won't be able to control the complications. So if you're suspecting ectopic pregnancy, or the patient comes with left iliac fossa pain, female, ectopic pregnancy, gynecologist should be on board if you're suspecting that. Send beta HCG levels. It is said it is ectopic pregnancy until and unless beta HCG or pregnancy test turns normal. Sigmoid diverticulitis and pelvic inflammatory diseases. They can also present with left lower quadrant pain. Again, ovarian torsion, it's a high yield emergency and you need to explore as soon as possible. If you're not in timely, you lose the ovaries. You might have to proceed for oophorectomy and other procedures to get rid of that ovary. But within time, if the patient presents to you within time and you're suspecting ovarian torsion, urgent surgery is required. You need to manipulate and you need to make things right for that patient. Again, urethral colic, renal stones, ureteric stones, important. So sometimes the patient might present with diffuse pain. He or she cannot localize the pain. And you ask the patient, where are you feeling the pain? And you say, whole of the abdomen, and you cannot differentiate. You even touch the right iliac fossa, it's paining. You touch the epigastric, the patient is tender. Drag the right hypochondrium, the patient is tender. So think of organs that might involve the peritoneum, or look for acute pancreatitis or peritonitis. These can present to you with generalized abdominal pain. And to be honest, this pain is really, really severe. And if you ask the patient to rate this pain, they definitely say it's 10 on 10. Bowel obstruction and appendicitis. Sometimes appendicitis do present with diffuse pain when there is perforated appendix. Bowel obstruction, especially small bowel obstruction, can present to you with diffuse pain. Mesenteric ischemia. What happens is ischemia. As I told before, with atherosclerosis, there's decreased blood supply to the intestines. With this decreased blood supply, the intestines are not being perfused adequately. So there starts necrosis inside the intestines. So with necrosis, there is generalized abdominal pain. So you need to intervene urgently. You need to get for an arteriogram, angiography, and just to get rid of that clot. Gastroenteritis and perforated bowel. Again, gastroenteritis with severe dehydration, yes, needs treatment. But perforated bowel needs emergency treatment. That's an important point. I keep emphasizing on emergency treatment because this is lecture about emergency medicine, and this is how you come across a patient in emergency, and that should be your approach when dealing a patient. Aortic dissection, rupture aortic aneurysm, again, explained before, emergency can present to you with diffuse pain. So another example of diffuse pain is sickle cell crisis. Sickle cell crisis is a genetic mutation in hemoglobin synthesis. It is type of point mutation. It has different type of crisis, hypertensive crisis, aplastic crisis. So sickle cell crisis can present with diffuse abdominal pain. Although sickle cell disease is asymptomatic at times, but when there is crisis, when there are symptoms, where there are features of sickle cell crisis, it may present with various symptoms, and diffuse abdominal pain is one of them. So this is the end of part 1 of how to manage a patient with abdominal pain. In this lecture, I tried and emphasized more on patients coming to emergency and what emergency treatment they need, how they should be managed, how should they be approached, what to do first, and what to do next after stabilizing the patient. It is essential for you working as a resident or a consultant or in emergency department. It is essential for you to recognize, acknowledge, and to treat as soon as possible when it's abdominal pain that can lead to massive and severe outcome. I also tried to explain the different type of pains with relation to their onset, their character, precisely emphasized on excruciating pains, because that's where most of the abdominal emergencies rely on. I tried to explain different locations or pain at different locations and organs underneath them or diseases that can show up with this kind of pain. In this next lecture, we will go further on how to take a history of a patient who is hemodynamically stable or who is made stable in emergency department. We will explain more or the associated symptoms with abdominal pain. Moreover, we will talk about the treatment of how a patient should be managed in ED with abdominal pain. The next thing would be special patients. That includes pediatric patients, pregnant patients, elderly males and females, how they are managed with abdominal pain. And some facts that are missed by us or emergency physicians that can lead to fatal outcomes. So some pitfalls and pearls will be discussed in the next section. I hope this lecture will be of some benefit. Thank you for watching sqadia.com. See you soon with the second part of abdominal pain. Keep watching sqadia.com.